Hi, everybody. We're back with the Frank Lizzie Show. Today we have Karen Rabbit. We're going to be talking to the Alliance Wound Care stakeholders about the recent final local coverage determination. There's been a lot of uncertainty over the years about skin subs or cellular tissue products, but now we're going to talk about details. In retrospective, I do want to say that make sure that if you have a biller or your administrator, that this applies to everybody because there's been a lot of changes. So, with that being said, I am Frank Aviles, one of your co-hosts, and with me, Lizzie.
Hi, how are you, Frank? And Karen, thank you so much for joining us again.
Thank you.
Thank you for having me.
Yeah. Well, we certainly really appreciate you coming on. Usually we speak to you guys every other month, but when the decision came out on November 15th, we thought, now's probably a really good time to reconvene. I'm sure the Alliance is getting a lot of calls, and I know this has been one that we've been talking about for a couple months here about as far as what's going to happen. So now we know.
Now we know. No,
So,
we sure do.
Yeah. So, for people that don't know what we're talking about, it is the final policy on skin substitute slash cellular tissue based products, camps, whatever you want to say, for diabetic foot ulcers and venous leg ulcers. And I know each of those ulcer types have a slightly different requirements, but why don't we just go over some of the high level points of what is different from the policy that we saw last year to what we're seeing this year?
Sure. So, first of all, I want to reiterate that this is just for diabetic foot and venous leg ulcers. So, those are the only indications that are covered under the policy. So, I just want to make that clear. Okay. So, any other indication, whatever's currently happening out in the field, is still happening out in the field, right? We're just talking about DFU and VLUs. And some of the high level changes, I mean, we're really happy that they made them, quite frankly, because in the past iterations of this, it was only 4 applications, period, end of story. But they increased it, and now it's up to 8. There's some restrictions, which we'll get into in a minute, about when you're billing more than 4, but now you can have up to 8 applications. And the episode of care is now 12 to 16 weeks, as opposed to just up to 12-week episodes. So those are 2 huge changes that we're really thrilled about. And those changes came about because people were providing evidence to the MACs to consider. And they said, well, even though our claims data doesn't really support more than 4 applications, with the evidence that we're seeing could go up to 8. So we're going to go ahead and do that. So, it goes to, having your voice heard.
So we got 4 more applications in 4 more weeks, but that doesn't necessarily mean that we'd be applying, weeks 13 through 16 every single week.
Right.
And
That's
certainly
right.
the episode of care is for each wound. Is that correct?
That's correct. That is correct. The number of applications and the episode of care is per wound. Correct.
and is there anything extra that you have to do, or can every DFU and VLU qualify for this?
Well, I mean, it's kind of what should already be taking place to start with, right? I mean, you have to make sure that you've got, the standard of care has been, had, and the wound hasn't made any progression or very little progression over a 4-week period of time, which they define as 28 days. But, some of the changes in the policy, Frank, to your point, is now the requirement for a patient with a DFU, you have to have the presence of a chronic non-infected DFU that's failed to achieve at least 50% ulcer reduction. That 50% ulcer reduction is new language. They didn't have that in the policy last time. I think it said it had to have something about measurable, the language measurable was in there, but here they're specifically saying 50% ulcer reduction. And they also talk about having a comprehensive patient assessment that includes a vascular assessment. And the vascular assessment language is also new. It used to just be an ABI. And now, of course, they're making it where you could have other things, to do that kind of vascular assessment, not just an ABI. But there are, I have to say, there's a lot of requirements. That was just the DFU. The VLU, you have to have an assessment of their clinical history that includes prior ulcers, higher body mass index, pulmonary embolism. I mean, they go through this whole list, edema, skin changes. So I would say that, the requirements, be very wise for any clinician in this space and any billers and coders that are responsible for filing these claims to carefully go through these policies and make sure that your requirements are being met before you're submitting a claim.
Yeah. And I'm kind of looking off to the side here, looking at like the claim or at the policy as we're speaking. And certainly there's even requirements in the DFU language that you have to review their glucose levels and their hemoglobin A1C, have to use an offloading device. And these are all things that really we should be doing anyway. But I love the fact that they took away like the ABI language, because there's so many great ways that you can assess vasculature. So like, Frank, what are ways that you would assess vasculature in your like lower extremity population?
I mean, like finding the pulse. No, I'm just kidding. But the reason why I wanted to say that before I answer that question is because I know we were talking before the program, and you would think that people were doing this, but recently there was a clinic that wasn't even measuring a patient. So this information that you're telling us, Karen, is very important if you want to be able to get paid for what you do. But there's other ways to do it. I've been using a lot of thermography, and I've been using near-infrared spectroscopy. And I'm going to tell you, we published 2 articles, and I realized that we didn't apply a lot of CTPs or skin subs because we were using technology to guide us. And so whether you're looking at vascular, whether you're looking at other components, I'm glad they changed the literature because that opens up these devices. And I'm hoping that we have coverage for them.
Yeah.
Right.
And
well, there's always that component, isn't there, Frank?
Right.
Coverage, yeah.
We've had a lot of challenges getting good vascular lab technicians that are doing the studies appropriately and thoroughly. And so I love the fact that we can use more objective point of care stuff like a vascular ultrasound, or like you said, the near infrared spectrometry, in order to really see what's happening with the patient and evaluate them that way. I think that's going to be super helpful, because much like we had an episode with a SEM scanner, and we were talking about how you never diagnose somebody with hypertension without getting a blood pressure, right? And so like for pressure injuries, you can use the SEM scanner, but certainly when you're looking at vasculature, you have to have a study to say that you do have good blood flow or you don't have good blood flow. And much to Frank's point, there's clinicians that say, oh, there's palpable pulses. It's totally fine.
Right.
Yeah. And Lizzie, the other thing I want to add is when you send your patients for an ABI, I guarantee you most clinics don't do it in-house. But now with technology, it's point of care. You have it right there, and you can make a quick decision and help that patient. So instead of waiting for that 4-week marker that we've talked about for years, now we look at the 1-week marker. So anyway, without getting sidetracked.
Well, and I think it's a really important change, and one that the Alliance really focused a lot of our comments on. So we were really happy to see that they took away the ABI solely and put in the vascular assessment or vascular perfusion, depending on what part of the policy you were looking at. So it's a good thing that they did, and we agree with it, and we're happy to see that change.
Yeah. And I think obviously the other big change is the approved list, right? So there's an approved list for diabetic foot ulcers, and there's approved lists for venous leg ulcers. And I know we've talked about this. Frank and I have talked about how, the people that are on the approved list really have a lot of data. So why don't you just speak to kind of the policy and how they came to approve certain products and not approve others?
Sure. So, so what they did, just so you know, they did create, as Lizzie had just mentioned. I mean, they created a covered Group 2 list. Those are products that just have indications for DFU, and then I believe there's 15 codes on that list. Not 15 products, mind you, 15 codes. And then they also created a group 3 covered list that those products have indications for both DFU and VLU or just for VLU. And there's 5 codes listed there. From the proposed to the final, they added Kerecis omega-3, they added New Shield, and they added Dermaglide. Why did they do that? Well, the companies had supplied additional data. The data that they had provided was not just RCTs. They also provided an additional comparative study as well that maybe wasn't an RCT, but it was a comparator. So it kind of complemented the RCT data, right? And so in reviewing that, the MAC said, hey, this data is really good. And because we find it to be sufficient, we're going to add those products to the covered list. So that's kind of what they did. They do say in the response to comments that they are not requiring RCTs. By the way, that is not a requirement, but they say it's the gold standard. So if there are other published literature, peer-reviewed, that the MACs find to be sufficient to meet their criteria, that doesn't have that has enough patients, that has comparators, that has all of these kind of this criteria, obviously they're going to consider it. But from what we've seen, right, like all the studies and all the products that they accepted so far all have RCTs. So that's you can take that for whatever it's worth.
Yeah. Karen, your background is not wound care, right?
That's correct.
Okay. So your background is legal advocacy and all that. So I'm going to ask this question,
Okay.
but you're the right person to answer this.
Maybe.
So if you had to create a checklist for providers,
yeah,
when it comes to this topic, before you apply or anything, or what would that checklist look like? You that have been involved with advocacy for us on wound care products.
I mean, look, if I rattled everything off on this show right now, we'd be here forever, right? What I would say is that there's a couple things. One, I'm going to give you a couple really important ones, but then I'm going to just say you have to go look at the policy. You have to make sure that you've got your checklist. You've got to make sure if you have an EMR or you have whatever system that they're flagging things for you, right? And being able to know when you need to do certain things, et cetera. For example, as part of the requirements in this policy, I remember I said there's up to 8 applications. Up to 4, it's not a problem. You're providing them, that's what their claims data shows. But anything over 4, you have to append a KX modifier. Now, other practitioners, PTs in particular, they're used to the KX modifier, but most people who are listening on your show are probably not used to using them, okay? That KX modifier is basically showing that you are providing more than, right, the 4 applications in this case. So as soon as you start, on application number 5, anything over the 12-week period, you have to append that KX modifier, okay? If you don't, your claim's going to get denied, period, okay? So keep that in mind. Now, with that KX modifier, there's additional documentation. Should that documentation already be done in the patient's file? Yes. You all should be doing this in terms of, has there been any wound progression? What product are you using? Blah, 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 right? I mean, okay. So there's that. That would be one highlight that I would say is new in the policy, but it would be a big O checkups, right? For me to say to your listeners. The second one has to do with product wastage. Okay. There's always been sort of these requirements about product wastage, but now there is a very specific requirement that you have to place a modifier on the claims if you have product wastage and if you don't have product wastage. It's not just, oh, if I haven't wasted anything, I don't need to do anything. That's not correct. So in this policy, they're saying you have to append the JW modifier for any discarded product. Okay, that has to be there. But then if you say, oh, I haven't wasted anything. I might have folded it over. No, that's not permitted here. Okay. It's not a fold over situation. That's wastage because it's not the appropriate size of the wound, right? So for if you don't have any, and you truly don't have any, that's the JZ modifier, and you are providing an attestation that you didn't discard anything. One of those two modifiers must be there because you either wasted some or you didn't, right? And if you don't have either of those modifiers, again, you're not going to get covered. It's going to get kicked out. Those are two really big ones. All right.
Yeah.
And I would say that, again, your documentation, I can't highlight this enough. Your documentation has to be pristine. It has to include everything about the patient's care, their conditions, what you've done, what standards of care you employed, what you've been doing, if the wound's been healing, any kind of progression, et cetera. That all needs to be documented in the patient's file. So I highly advise, encourage, urge all of your listeners to please go through this policy and make sure that they're paying attention to the documentation requirements, but also these coding requirements, because that KX modifier and the JZJW modifier must be included or the claims will be denied. We're providing a list of these kinds of questions and clarifications to the MACs as well as to CMS to try to gain some additional information. There's some questions about multiple wounds that we're trying to address because in the policy they're talking about the sum total. When you're doing this, and this isn't new, by the way, but when you're looking at wounds on the same anatomic site, if you have multiple wounds that are on the same anatomic site, you're doing a sum total, right? But with this policy of the 4 applications to 8 applications, right? Like whatever you're doing, if you have a new wound that you're then adding into the sum total of what you already had, how are they going to determine whether you're at the 4 application, then you have to append the KX modifier for that new wound versus not, right? I mean, so there's still some ambiguity, right? And so we're looking into all of these kinds of questions that we hope to be able to provide to our members at least. And then hopefully with that, the MACs will issue either a frequently asked questions document or within their town hall meeting that they're hosting on December 10th, maybe they'll be able to address some of those then.
Right. Well, this is super helpful. I mean, I think we could probably talk on and on about this, and certainly there's going to be a lot of updates.
Yeah.
I do want to remind our listeners that to make sure you follow the Alliance on LinkedIn for real-time updates. You can also visit the website woundcarestakeholders.org, or if you're a member of an association like the APMA or AAWC, they offer updates about what the Alliance is doing for us as well, to be the unified voice for wound care, which we appreciate so much. And then I think there's just one more question, and that is, when will this be taking place?
Yes. So this goes live on February 12th of 2025. So normally there's a 45-day implementation period. But this time they're affording us 90. And in large part, that was because the Alliance and others were very specific about not wanting to have an interruption of care. And if they implemented it in 45 days, somebody's treatment plan was going to be interrupted.
Yeah.
And so they are giving a lot of advance notice here for a go live on February 12th of 2025. And one thing I also wanted to say, Lizzie, real fast, is the Alliance is also going to be putting on a webinar at some point on this very issue that we're going to be talking a lot about how to implement a lot of these changes. So stay tuned for that as well. So if your listeners want to participate in that, they're certainly welcome to do so.
Great. We love that. Thank you so much for offering us these updates, and hopefully we can continue to offer the audience more updates as we know more and clarify what I'm going to deem as the naughty or nice list, given that we're so close to Christmas now, that you're taking back to them to determine what's what.
Yeah, let's hope so.
Yeah, thank you so much, Karen. Very enlightful. and I want to keep listening to you.
Thank you. I appreciate being here, and hopefully everybody has a wonderful Thanksgiving and a wonderful holiday. So thank you.
Thanks. All right. Well, everybody make sure that you like and subscribe the Frank and Lizzie Show so that you get all the updates from the Alliance, and also visit the Alliance on LinkedIn or their website in order to keep up to date with the latest and greatest. Thank you guys so much.